Hello and welcome to the EMSNation podcast. I'm your host, Faizan Arshad. We are doing a live podcast from none other than Nash Vegas in Nashville, Tennessee at the EMS World Expo. We are just concluding our first pre-conference day at the World Trauma Symposium. And let me tell you, this year was like no other. The content that was presented was so tactical with an amazing amount of takeaway points that we felt obligated to assemble a fantastic panel to talk about the highlights, some of the takeaways, and their unique perspective as providers and how they're going to take some of this information back to their own municipalities to help set up and advance their care within their own neighborhoods and homes. So without further ado, we'll go and introduce our panel.
Hi, Mike Brown. Super excited to be here and be talking about this today. Really got pumped when I listened to the intro podcast that Dr. Arshad had done, and this definitely didn't disappoint. It was a great day. I'm from Fort Wayne, Indiana. I'm a full-time firefighter paramedic there. And I also work part-time as a flight paramedic for a service there in Fort Wayne.
Hi, I'm Dave Jensen. I'm from Vassar Brothers Medical Center in Poughkeepsie, New York. I am also an active field paramedic with NDP EMS, providing care to the residents of Dutchess County. I came to the World Trauma Symposium today with a super excitement of wanting to learn knowledge, and all of the things that were provided today were absolutely wonderful.
Yeah, hello. My name is Jesse Pitlow. I'm an anesthesiologist from faraway Switzerland. Well, that might surprise American auditors, but in Europe, especially in Switzerland, anesthesiologists are heavily involved in pre-hospital care. So my job is as an EMS physician as well, and I've flown countless years as a flight physician in helicopter and mountain rescue.
So without further ado, let's dig into our session today. So first up on our day, we had hemorrhage control before the airway from none other than Dr. Kenji Inaba. And I thought this was a fantastic, great way to start the day with an introduction to some basics, yet nevertheless incredibly important to emphasize that in regards to the tactical environment, it's basic interventions that save lives. And I think Dr. Inaba definitely brought that point home.
Absolutely. We have been working for years according to the ATLS principle, A, B, C, D, E, airway comes first. I'm an anesthesiologist, of course. But in the last years, we came to realize actually, and it was at the beginning quite a shocker, that we had to think it over, because in major trauma, not only does major bleeding kill faster than any other problem, but that it can be fixed with very simple means, while airway maneuvers are much more time consuming and much more difficult. So it's sort of a paradigm change, and we'll have to get used to it. And Dr. Inaba showed this. Yeah, of course, he's a terrific speaker. I met him countless times in Europe, and he drove the point home. Really brilliant.
Yeah, he did do an amazing job of just kind of reinforcing getting back to the basics, and it really kind of resonated from the PHTLS instructor update that we did yesterday, where we talked about the X, A, B, C, D, E transition, with the X being exsanguination. And this really drove home the importance of making sure that severe bleeding is controlled and that we do that early. Something else that was a good takeaway for me was that data didn't support the use of hemostatics over plain gauze, and it drove home the importance of good pressure control of bleeding, and good wound packing and things like that. And there's a lot of agencies struggle with we can't really afford hemostatic agents, but everybody has gauze. So if we can just make sure that we know that good pressure and good packing of wounds can really help out with those hard to compress and hard to control bleeds.
I think he broke it down for me in very easy to understand means. So we have external versus internal hemorrhage, and then we have compressible versus non-compressible hemorrhage. So really, when we talk about saving lives and the means of exsanguination in our patient population, we have to drill down and train like we fight. When we talk about wound packing, how many of us are aggressively wound packing, right? And later on in the morning, another one of our speakers presented a video where a woman was having one of our wounds packed in the background, and it literally sounded like murder. But it is, in fact, a very important life-saving intervention, especially for junctional hemorrhages. We need to practice wound packing. We need to be aggressive. And this is a learned skill that we can all upgrade and or brush the rust off so that when the need arises, we have the opportunity to save a life.
One of the other things that we learned in one of the videos that he showed was that the improper location of a pressure bandage can give the effect that you're applying pressure, but it's incorrectly being applied, and the patient is bleeding out underneath the gauze. By applying a small amount of gauze to the direct point that you need to apply it, is a much more effective use of the tool. One of the things that I found interesting was Dr. Anabi's presentation on using powdered anticoagulants, or powdered hemorrhage control devices, and how they can be washed off, how they can embolize into the system. So those are things that my takeaways from that.
Yeah, that's really a good point, because people actually compressing a wound it sounds as something fairly simple, but even in the hospital you see people doing it incorrectly. And we had a case in my county where a policeman almost bled to death just because people were in a panic and put a pressure dressing but at the wrong place. And that's, again, that very simple, but you have to teach people these very simple moves. Our medical director in Switzerland always used to say that simple things are important and important things are simple. That's a good example, in my opinion.
I love that. Dr. Balger was next up on the agenda, and she is quite a heavy hitter on the national trauma scene. As part of the American College of Surgeons, chief of the Committee on Trauma, she broke down the future of EMS as well as the national trauma system and framed trauma as a public health problem and indeed a public health emergency, and started talking about the national trauma system of care and decreasing preventable death and disability.
Yeah, it was a great talk, and she really did a nice job, just like Dr. Arshad said, of framing that up really well. One of the takeaways that I found interesting was when she talked about lactate being a better measure than shock index, and I kind of started to think about that and how it had implications to EMS, and because not a lot of EMS agencies have point of care testing, so can we really do serial lactates? No, we probably can't, but a lot of us know about the inverse relationship of end tidal CO2 to lactate, and everybody in an ambulance should be able to, at least an ALS ambulance should be able to monitor end tidal CO2 and breath by breath be able to be kind of indirectly monitoring that. And
that's a really good point, Mike, because she told us well that we tend to under triage older patients, and of course we're used to learn about shock in young healthy American soldiers, and that's clear. You have a blood pressure going down, you have a guy who is tachycardic. Now you have an older person who is on beta blockers, who take anticoagulants, who maybe has atrial fibrillation, and then it gets much more complicated. And in my opinion, actually lactate is the perfect answer. It's not complicated, it's cheap, and it's performant. In the hospital, I do it every day. Well, there is no reason why it shouldn't work in the field.
Yeah. Interestingly, some of the studies looking at sepsis and lactate haven't borne out fruit, but nevertheless, as an indicator for trauma, it has certainly interesting potential. In regards to potential, I found her nuancing or alluding to the future and the incorporation of technology in the advanced notification and automatic dispatch of trauma services very intriguing. And this was something that was introduced to me by one of my Australian colleagues, Brian Burns, at SMAC this past year in Germany, where he talked about the future of EMS and advanced automatic crash notification and the in automatic intrusion being a criteria. I know that OnStar and GM have developed great notification tools. They have incredible data and objective measures that they're actively charting, whether airbags deployed, how many patients are in the vehicle, whether they were wearing their seatbelts, is the windshield cracked or injured. And then the future also, now tying this to our personal trackers, whether that be a Fitbit, a smartwatch, a Garmin. In the near future, not only are you going to be able to get heart rate data on that patient, which is going to be integrated with Bluetooth in the vehicle, it's theoretically possible we're also going to be having blood pressure monitoring and maybe even pulse oximetry within these devices. So integrating all those things into a unified response system so that the individual does not even have to call 911, but it's an automatic dispatch, has a very exciting prospect for future interventions, I think.
I found the discussion about point-of-care testing with lactates very intriguing as well, and that is something that could be used effectively in the field. To modify vital sign criteria for the elderly is something that we need to make sure that we look into and are proficient in. That a fall from a normal position in an elderly patient not only can include a hip injury, but also can include other modalities of injury. And her summary of the training to make sure that we know the recognition of pattern of injuries, and that the direction of a particular patient in a car accident and the trajectory of the accident can dictate where those injuries are in those patients.
Another good point too, in regards to the triaging of patients, she referenced the 2011 CDC field triage decision guidelines. And she made the point that, in fact, as practitioners in the U.S., there's some ageism being perhaps unwittingly practiced. And then for our elderly and geriatric patients, we're oftentimes defaulting to provider gestalt, like, doc, I just think he's sick, so I brought him to the trauma center, and we're foregoing those CDC guidelines. I know we use them quite a bit in our trauma activation scheme in the Hudson Valley, but I was excited. That was new news for me that NHTSA is going to be revising the field triage guidelines, likely in 2019, and is going to include specific guidelines for geriatric population as well as for pediatrics.
Yeah. A very good point she made is actually how it is actually the importance of the system. That's something you guys in the US understood much sooner than we did in Europe. However, it's incredibly important. Whenever I teach a PHTLS course, I always tell to my providers, hey, do you guys want to learn a technique which will improve the survival of your patients by 25%? And of course, everyone raised their hand and say, yes, I want to. I'm a big-time anesthesiologist. They're sure I'm going to teach them Reboa or some weird kind of intubation. And I say, no. You read the triage guidelines of the American College of Surgeons, and you use them in your daily life because they have been proved to improve the survival by more than 25%, and that's just saying that way more than pre-hospital intubation.
Mm-hmm. Absolutely.
Just saying.
Some of the things that Dr. Bolger highlighted as opportunities for EMS to improve in the future were to support bystander training and stop the bleed, to integrate law enforcement into our training and medical training, especially in active shooter events, readiness of training of military medics, adoption of best practices in standardizing care, optimizing field triage, blood product resuscitation, and robust QI and benchmarking performance of EMS.
I think that's a great transition to the next topic, which was done by the medical director of AMR, Dr. Ed Rocht, the role of private sector EMS in times of crisis. And he did a broad overview of the response of some of his services to the Las Vegas shooting in October of last year. And this lecture was absolutely fascinating. There are so many nuanced points that he brought to the surface that had never occurred to me. There's quite a few takeaway points that I met. He started his conversation by showing the system status management, or in other words, he had a dynamic map of all the ambulances in that particular area as they were responding to the event in question, and he could show the ambulances actively responding. I thought that was incredibly neat. But the concern there is also, what about the surrounding communities that are still having active medical issues? People are having MIs, they're getting into accidents and fracturing hips. But he brought together a great point in showing that system status and active management can be incredibly helpful. But in 2018, we do need backup ambulances, mutual aid, and automatic dispatch intervention should also be in place from the communication center, especially when these mass casualty scenarios or active shooter events are ongoing.
Yeah, it was a great talk. If you missed this one, you really missed out. He did a really nice job giving us kind of a recap of what had occurred. One of the big takeaways for me that I didn't really think of until he talked about it is, every agency probably has a mass casualty trailer that they keep readied with a bunch of long spine boards that we've now learned are evil. But there's not a lot of extra bleeding control supplies in a lot of those trailers. And he had mentioned that as something that kind of came out of their after action and something to consider. And I wanted to throw that out there because it wasn't something that I thought of. And I think that might be something valuable for you folks as listeners to think about and maybe have your agency pursue, because you're potentially in an event like that, you're going to run short on those supplies fairly quickly. Depending on the number of injured, you could need a lot of commercial product that just is not available at the time. So that was one of the big takeaways for me, that is something that's definitely going to go home with me, that I'm going to try and change. He also talked about how helpful Uber and Lyft was out in Vegas.
That was fascinating.
And I didn't really think about that.
But they were, in fact, incredibly helpful.
Yeah, and we joke about it a lot, but it sounds like it really did have an impact there.
I think one of his points was the ride-hailing services are using active GPS, so you know where the vehicle is and they know where you are. So it really helps and facilitated the decompression of the hot zone in this particular scenario.
One of the portions of his talk that I found interesting was the fact that start triage was abandoned very early in the process, and they were obtaining a new level of triage. And that the patients and the crowd were seeking cover from an elevated event on 1 October, but they were using the buddy system. They were using improvised tourniquets, improvised pieces of clothing to pack wounds. And a lot of the dynamic things that we do when we do a patient assessment and we're looking at a patient that has blood on them, we think that they're bleeding, and that blood may not be theirs. It may be from another patient that they were assisting. That was one of the things. The other thing that was interesting is how Sunrise, the trauma director at Sunrise Hospital in Las Vegas, decompressed his ED, which is very interesting. Took the patients that could be shipped out to tertiary hospitals in the area to care for and open up the trauma services in the ED was very important, because Uber and Lyft were bringing those patients to those hospitals.
That was a learning point for me too. In the event of a disaster, a hospital may write into their bylaws to circumvent EMTALA regulations that, you know, non-critical patients can actually be transported to another hospital for definitive care. That was a fascinating learning point for me, and I think a great takeaway. There were a couple of sad points that he brought up as well, aside from the high number of casualties and fatalities. You know, he stressed the importance of a perimeter search. You know, certainly on the federal level, we advocate run, hide, fight for those bystanders that are involved in a potential active shooter or mass casualty. But there were several bodies that were found the morning after or even days later because they were in fact hiding and they had exsanguinated by themselves without anybody to comfort them in their last moments, which was incredibly sad. So one of his takeaways there was, you know, if you have the wherewithal during one of these events, you know, find a buddy, stay with your buddy so that you guys can, you know, safely evacuate the area. And for the emotional and psychological stress that the providers also suffered, he recanted a story of a brand new EMT, barely 18 years old, who was traumatized, essentially had PTSD and recurring memories of the bodies and, you know, the importance of coming together as a system and having, you know, just a psychological aid in not mandating what we now know is harmful, the CISM, the Critical Incident Stress Management, but rather just allowing the opportunity for those folks who want to decompress, talk more, or seek additional therapy. And I know AMR also brought in therapy dogs, which was quite therapeutic for the boots on the ground.
One of the other things that he discussed is the fact that you have a written disaster protocol, and that disaster protocol basically goes out the door in an event like this, and where it's the best practices of the boots on the ground providing the care.
Absolutely, I was really impressed by his moving map, and it reminded us of something important. One very difficult aspect of any mass casualty incident is not to forget that the life is going on around us. I was once involved in a mass casualty in Switzerland, and in a small hospital, and actually I had one of my chief residents running around the hospital just to make sure that nothing was happening in the OBGI, in the ICU, in the cardiac surgery suite, because that's the danger, and nobody's going to forgive you if you miss an emergency C-section or if your cardiac patient dies, even if there was some big time event unfolding on the street. So that was a really interesting point, which is often forgotten.
Yeah, I think I did a rotation with SAMU de Paris, and one of the greatest points that Dr. Lionel Lamoux was telling me was, even after the Bataclan Paris shootings, in a relatively short order, they had active system status management, and the surrounding regions were now covering the areas, and so their 911 response time did not change during that entire disaster.
That's what they call a concentric alarm, actually. They have a special term for that.
Beautiful. Dr. Deborah Stein transitioned our morning to talk about traumatic brain injury management and detection.
Yeah, that was a really interesting talk, because, you know, now we speak very much about hemorrhage as a preventable death cause, but traumatic brain injury might not kill you, but it might destroy your life. It has a devastating impact on the quality of life, and in the last year we came to recognize the importance of so-called mild head trauma, and in America, especially, I think in the Army and in the NFL, they did a terrific job at actually uncovering this problem, which is mild head injury, which is actually not mild at all.
Yeah, absolutely. The old adage, to walk it off, is proving not to be true, because recurrent mild head injuries can result in significant long-term disability. I think what's perplexing, though, is regardless of how many assays or tests or interventions we try to impose on TBI and head injury, it seems like some of the basics are the most important. And this was definitely an emphasis for us in PH-TLS, is prevent hypoxia and maintain normal tension. Do not allow your patient to become hypotensive.
Yeah, and that kind of brings into a good point that she brought up that resonated well with me, is that we need to consider different blood pressure thresholds for our elderly patients, because they need a higher blood pressure to maintain that physiologic status that they need to keep perfusing the brain. So that was a good takeaway for me, and remembering that while we want to always combat hypoxia and hypotension, we need to be cognizant of hyperoxia as well. Absolutely. And remember that oxygen's a drug, and we need to be giving that as it's clinically appropriate.
One of the things that Dr. Stein brought up was the use of biomarkers to rule out the altered mental status that could be caused by alcohol or drug intoxication versus an actual traumatic brain injury. And the possibility of that being a point of care type testing in certain markets where you have large festivals and you have a large number of altered mental status patients in your medical tent, you need to be able to rule out the fact that they have a brain injury. The other thing that she brought up was the use of an algorithm for treating your TBI patients. The one hypoxic event in a traumatic brain injury patient is a 56% increase in mortality. So those are definitely things, but giving too much oxygen is bad as well.
Excellent. Next up, we had the medical response to the Manchester bombing with Richard Smith, who joined us from the UK and provided a great perspective as an anesthetist responding to this mass casualty situation as a rescue response physician. I really enjoyed his approach as a medical director in helping not only triage, but especially the treatment of his patients that he was receiving, because in the pre-hospital sphere, we're very, very dedicated to our protocols and our scope of practice. But sometimes in disaster scenarios, our protocols are insufficient to deal with the challenges that we're actively facing. And one thing that he was noted for was using ketamine in small recurrent doses, just to manage pain, but to, in small enough doses so that the patient remained awake, had intact airway reflexes. And this was a deviation from, the typical protocol, because, the physician would otherwise be mandated to stay with that patient, but he was working on treating several patients at the same time. Another thing that they flexed on was IO access for folks who needed resuscitation and access and medications. It was not your typical cardiac arrest scenario, but nevertheless, if IV access was unattainable, they would just pursue IO access so that they could help manage these, multi-injured patients.
And for me, it was just he was an excellent speaker and did a really nice job painting a picture and telling us about the event. And it was cool for me to see how there's a lot of similarities in the way that things function over there as they do here at the mass casualty events, and how he just kind of had to game day, improvise, adapt, and overcome a little bit. Kind of like Dr. Arshad had said about the ketamine, and that's kind of a game day thing with having the providers that in their system aren't ordinarily able to take that patient and then be able to get that done day of.
One of the takeaways that I found interesting was the use of a tool that they have in every first responder vehicle or gear bag that uses, it's a card type system where they can hand one card to an individual, and that is their unit job status that they have for that particular incident, and how they can play cards into multiple roles and use those as an effective tool to manage the incident. The other was the reminder to make sure that we re-triage our patients as they come through our systems. So he told a story of a pediatric patient that was being walked from the scene by a parent, and both of the patients were determined to be green, when in fact the pediatric patient was a red, and it was a near miss on their issue. And it just resonates with myself to make sure that during MCI events, just because they could walk away from the scene doesn't mean that they're green through the entire scene.
That's a good point, James, because I guess it was an American general who said that no battle plan survived the contact with the enemy. And actually, when you see these disaster plans are actually, we used to say disaster plans are a disaster by themselves, because you can, you have to find your own solution, and from times to time. And for example, start triage. Yeah, it's a very practical tool, but it has its limitation. Actually, the beauty of having trained people in a mass casualty incident is that they can work around the limitation of our plans and checklists and triage, which are a useful tool, of course, but they are no gospel, and we have to sometimes to work around the limitations.
Absolutely. I think that's worth noting that in the pre-hospital and out-of-hospital sphere, we are challenged with limitations. We are challenged with situations in which, despite our best efforts and interventions, the outcome that we desire is unattainable. And just being in this profession, it's inevitable that we will all suffer some sort of psychological trauma. Our next speaker was Kimberly Roaten, and she's talked about caring for ourselves, a critical component of resilience. And just finishing up our National Suicide Prevention Month and Mental Health Awareness Month, this lecture was incredibly timely but also tactical. I think, as first responders, we don't like to talk about this subject very much. We certainly all or many of us have a superhero complex. We got into first response so that we could save lives. But we have to remember, in order to best benefit our patients, our own mental health, physical health, and spiritual health need to be in optimal states so that we can provide medicine in the best way possible. So Kim really, helped us understand that, but she had a positive frame for that. And that even though the post-traumatic stress response can vary greatly, if we cognitively reframe that event, it can also be an opportunity for post-traumatic growth. And in fact, if folks are able to use a challenging situation as a means of self-development, it can be incredibly powerful.
Yeah, and this really was this was a great talk, and it's near and dear to my heart, something that I'm really passionate about. And if there's anybody out there listening that your agency doesn't have any kind of peer support in place, or any kind of psychological first aid or whatever you want to term it, please make sure that you reach out there and get it. Unfortunately, we lost more firefighters last year to suicide than to line of duty deaths, and that's a trend that I don't really want to see continue. I've unfortunately lost a coworker to suicide, and it's very difficult. So that's why I would urge anyone that if you don't have a program, please do something with your agency, get it set up. Hopefully we're to the point now where anybody that's working for an agency hopefully has access to those services. But I don't want anybody to have to go through an experience where it's too late to be able to help somebody.
Thanks for sharing that, Mike. We definitely want folks to get the help that they need. But there's another flip side to that is we want them to get the right help. So this is an opportunity for us to talk about, do no harm, because we in the past have been in such a rush to introduce some sort of psychological tool that there was wide adoption of the CISM program, the Critical Incident Stress Management Response. And it's ultimately borne out through research that not only is it just not neutral, it can in fact be detrimental to the mental health of providers by mandating that they have a hot wash or a debriefing, and that can in fact worsen the psychological stress. So she really emphasized the importance of psychological first aid as a component of a peer support program. And I think we are looking forward to scheduling a dedicated podcast with Kim so that she can help us expound upon that point. And for folks who don't have, that sort of psychological first aid program within their service, she's going to give us some tactics and takeaway messages for us to incorporate and really bring the best evidence-based psychological response for the daily and chronic stress that we undergo.
I found one of the things that Kim talked about was burnout with the individuals that have gone on these type of calls, and the emotional exhaustion and the depression, the depersonalization that occurs in the providers. And we typically don't see that in the newer providers or the EMS dinosaurs, as we call them, but they're typically the 5 to 15 year experienced paramedics that it's more prevalent than in EMTs. And using properly trained peer support, peer-to-peer support, is important because it allows the provider to talk out the call or the situation almost immediately, rather than waiting for the department psychologist or the department healthcare provider to be able to talk to. The other thing is there are a number of organizations out there that currently do these type of things. Project Green is one of those support mechanisms that can be used. Reach out to your medical campaign director during a time of crisis. Anything that you can do to talk it out and get it off of your chest. Your partner is probably one of your best. When you're inside of an ambulance for 24 hours with somebody, you learn more about that person than ever. And those type of people are the ones that you can talk to the most. You can't take it home and talk to your wife about it. You can't take it home and talk to your kids about it. And you feel that it's trapped inside of you, but you need to talk it out. And sometimes your partner is the best person to talk it out, but reach out for help.
Absolutely. We're going to fast forward a little bit and jump into the afternoon sessions. Dr. Megan Brenner talked about REBOA, which is, of course, a very sexy topic, the resuscitative endovascular balloon occlusion of the aorta, and compared it directly to ED thoracotomy for direct source control. So in other words, can you cross-clamp an aorta faster via thoracotomy, or can you potentially get a REBOA balloon up faster using a minimally invasive approach? And she sort of brought us through the timeline and the evolution of the catheter and the procedure itself. Once we started in 2013 with this procedure, we were using 12 French catheters. And now in 2016, we're using 7 French, so significantly smaller catheters. In addition, there's no guide wire necessary, so they can actually be placed faster for definitive source control.
Yeah, it was a great lecture. I enjoyed it as well, and I liked how she referenced it as regional permissive hypotension.
That was great.
I thought that was pretty cool, and particularly where you can just regionally allow that hypotension to hopefully control those junctional bleeds or otherwise non-compressible hemorrhage sites. I think there's she presented some really good evidence for it, but I think we may be a little bit of ways away from it before we see it in the pre-hospital arena where I'm at currently, particularly in systems that aren't responding with physicians.
Yeah, I guess even within the system responding with physician, actually we have to consider that such a technique can only work if you have a whole system which is set for that. First time we spoke about Reboa in Switzerland, which is really a nutshell. But I asked my colleagues if they had seen the Jungle Book. The Jungle Book, you have that scene where the Baloo, the bear,
yes,
grabs the tiger by the tail to protect the kid, and after some time you have the vultures telling me, "Hey, you can't let him go. The kid is safe now," and the bear is down there. "Let it go. It's a tiger. I can't." And actually, Reboa is a little bit the same. Okay, let's say you're a good anesthesiologist. You put on a Reboa, then you just have clamped the aorta, and you have a lot of evidence that the zone 1 the Reboa, that you have about 15 to 30 minutes maximum to fix the problem. If not, you have a very, very angry tiger turning back at you. And so if you don't have a system which is perfectly set up to handle such a problem, well, in my opinion, just wasting time and money.
Yeah, I think the outcomes data is still very unclear, and she was forthcoming about that as is a potential for benefit. But again, like many other things, just like the ED ECMO program or the CPR program in Paris, for example, where they're doing the cannulation and starting the patients on bypass in the field, the biggest challenge is patient selection. So what patient is likely to benefit from my intervention, because resources are never going to be unlimited in that setting. So really, further prospective research, greater training, skill maintenance, selecting these in dedicated trauma centers where folks are performing this procedure on a regular basis to maintain competency. One interesting application, though, is the military, where a recent paper from the U.S. Air Force in July 2018 described Reboa as a force multiplier, especially in the austere environment, because could be a potential for mitigating a problem until you can get them to definitive source control. But nevertheless, a lot more to come on that in the future.
My takeaway from her talk was to move the patient towards definitive care. Doing the procedures in the field, yes, but you're doing them while you're moving. So this procedure was done in a moving ambulance, which is definitive to the patient having that time window closed down. So when the zone 1 or the zone 3 position of the balloon allows for a certain amount of time, but the pre-hospital time multiplies or doubles the amount of time that the patient is in the ER, and all those times have to add up and conclude in a positive outcome for the patient. Otherwise, we're not doing any good.
Agreed. Speaking of not doing any good, the next lecture was definitely one of my favorites by a pediatric emergency medicine physician, Julie Leonard, assessing children for the risk of cervical spine injury after blunt trauma.
Yeah, that was actually a very interesting session, because I'm one of these EMS dinosaurs. I took my first ATLS course it was back in '91, just telling. And at that time, we learned actually to be quite paranoid about C-spine immobilization, which was probably a good thing, I can tell you, because in the ancient time where people weren't paying attention at all, we had our kind of problems. Still, we were thinking we were doing the patient a huge favor by doing all this immobilization stuff. And by now we realize actually not only that we are not doing so much good as we possibly thought, but that we're doing some harm as well. Even in kids who are the most resistant patients we can possibly get.
A couple of the points that she delivered were the efficiency unknown and possible harms of backboarding these patients, and that there was no evidence that limits the neurological injury from some evidence that associates worse outcomes, potential for non-physiological positioning. In the critically injured, it impairs airway management and ventilation, increases ICP, and causes ulcers in pressure points. It causes for pain to be increased in patients and also causes increased reliance on imaging. And we all know that we've moved on from imaging as an X-ray to now imaging as a CT. And the use of the CT for other critical patients in the ED can be limited when we have multiple patients being CT'd.
Yeah, spinal motion restriction remains a touchy topic, and in PHTLS, we certainly approached it from an evidence-based approach. And I love that, she's certainly an academician. As part of the PCARN study group, they collect the best evidence all across the world to make very rational decisions. And one of the concerns regarding the increased reliance on diagnostic imaging is the exponential increase in the CTs for pediatrics due to the trickle-down effect of the PAN scan for adult trauma patients. So she was showing graphs which showed a increase of over 500% of CT utilization in children, and especially when you're talking about the head and neck area. She directly correlated that to increased cancer risks. And, these are things that as providers in the emergency department, we're not having conversations with our patients in regards to informed consent and shared decision-making regarding the risks of, ionizing radiation when you're talking about diagnostic imaging. So I think, the PCARN data has been tremendous as an ED provider, just in reducing the CT utilization for, mild head injury when the patient has an intact GCS and, a normal neurologic exam. So I am incredibly grateful for the effort of this work group and really look forward to more to come from them.
Definitely, without a doubt. And just to kind of piggyback on that a little bit, she had brought up a study of 2,634 adults that were irradiated at some point during their childhood, and 309, or what would be 1 in 9 of those, developed thyroid cancer, and 1 in 3 had developed nodules. That really kind of resonated for me. And she said that there was an ultra high risk if they were under 4 years of age. So just thinking about as an EMS provider, making sure that I, of course, follow local protocols, but I want to practice that spinal motion restriction when it's clinically indicated and not be over immobilizing my patients.
The rest of the afternoon definitely finished off with a bang. So we got into the whole rescue task force debate, but right before that, one of our debate participants, Mike Klumpner, talked about intentional injuries and novel mechanisms. So bringing awareness to, atypical forms of attack or terrorism or any sort of mass casualty injury. And, certainly in the U.S. we have issues with handguns and firearms. But one thing he brought to light, which I was definitely unaware of, was, for example, acid attacks in the United Kingdom and Europe.
Absolutely, that was a terrific talk. Actually, Mike was just great. First, because he showed that a very scary fact that we are doing our continuing education to get better and better at responding at incident, but the bad guys are doing their continuing educations as well. And they're doing
Frightening.
so in a big way. As you know, there is much debate in the U.S. about firearm, but as a European, I have to tell you, the worst terrorist attack they had in France was done actually with a truck, and I never heard they're gonna ban truck in France. They could never do it.
He had so many great takeaways. I think he has a tremendous amount of experience as both fire, police, EMS, law enforcement, incident command, unified command with a rescue task force. I think some great points he had was in a crisis site with triage, you either red or dead. And I think that brought an important point that was sort of nuanced by speakers earlier. We love to teach, certainly as medical directors, this methodological approach to triage and, red, yellow, green, et cetera, orange maybe if you're in New York City. But in a chaotic situation, those systems can certainly fall apart. And really, it's getting folks off of the scene to definitive care while not getting your local hospitals overwhelmed and maintaining that capacity for critical patients. That's the most important goal.
Oh yeah, definitely. I mean, without a doubt, he had all the background and was an excellent speaker. I really enjoyed it. He also talked about their odds of mortality increases 2 to 4% every minute until they reach a surgical suite. So that just kind of drives home.
Yeah, and Mike, that's very kind of you not to mention another slide he had, that if you're shot and you have an EMT on your side, you have, say, about 20% chances of dying. If you had a paramedic, it went up to 25%. And if it was a doctor, we were about 32%, I guess it was. And you know the worst part? I'm sure he's right.
Well, I was trying to be kind to you and not bring that up.
This was an absolutely beautiful take-home point that I think we don't emphasize. We all think about the poetry of a mass casualty incident and how sometimes when we don't have the capacity to offload patients, our, of course, inclination is to set up a casualty collection point, designate a field supervisor to be, leading that section, and then we might initiate treatment. But we have to appreciate is that the simple act of establishing a casualty collection point will increase the time that each individual patient is on scene anywhere from 3 to 20 minutes. And that time on scene is not benefiting the patient. We need to get them in a traumatic scenario or event to the hospital, to the trauma surgeon, to the trauma team. And he sort of redefined or cognitively reframed the CCP using another term instead called the AEP, rather the ambulance extraction point. So he said, while trying to choose a point for a CCP, make it in a place, if you are able to, that's also accessible for egress so that you can actually set your patients up for success by getting them off scene.
A couple of the things that I noticed in his presentation were not only are we active shooter or improvised explosive devices, but we talk about fire as a weapon. We talked about chemical attacks. We talked about mass stabbers. And one of the slides that really stung home to me is in a review of 100 active shooter cases in the United States. Death and serious injury occurred every 15 seconds after the event starts. But if in the transitioning of the event, which needs to be noted by the incident commander and the teams that are inside, if there's a 5-minute window of not having any shooting, that the shooter is either dead by self means, in custody, or fled. And the recognition of that transition of the event is when we can save a lot of these patients. Establishing a mass hemorrhage runner.
This was great. I really like this idea.
Yeah,
on the first arriving units, instead of start triage where we take 30 to 60 seconds at each patient. By the time we get to patient number 8 who's extenuating, we can lose that patient. Rather, take as many hemorrhage control devices that you have and rapidly go through the scene and apply those to the individuals that can. And if they can self-apply them and move on, let them self-apply it and move on.
Yeah, because you might methodologically be approaching triage, and by patient 6, patients 10 to 100 may have exsanguinated. So the idea of, in this type of, if the mass casualties with penetrating trauma, perhaps an active shooter, and you have the ability to walk the, the site or the means, then a mass casualty runner for hemorrhage control, as opposed to your standard approach for triage, might be an incredible intervention that could lead to more lives saved.
One of the other points that he made was integrating training amongst fire, EMS, and law enforcement, and how important it is for them to have TCCC or TECC training so that they can understand that fire, EMS, and law enforcement can understand the needs of these patients.
In regards to that interagency training, we completed this excellent day with a debate on the Rescue Task Force. And for those who don't know, the Rescue Task Force is a concept where, in addition to law enforcement officers entering the scene to neutralize the threat, is the idea that in the warm zone, there may be casualties who are salvageable. How do we approach them? How do we extricate them? How do we get them off scene into the cold zone so that we can initiate life-saving means and interventions, and then ultimately work to transport them to the hospital for definitive care? There's been a tremendous amount of concern, especially after the Hartford consensus and the Sandy Hook shooting, that law enforcement, fire, and EMS needed to work together. It was a clear mandate in order to save more lives. In addition, tactical training would definitely result in more lives saved. So the Rescue Task Force is a concept that under force protection, fire and EMS with law enforcement in a trained and cohesive unit can potentially enter a warm zone to start initiating basic life-saving maneuvers and extricating patients. Obviously, a lot of controversy associated with that, and we got into it.
Yeah, I think the Rescue Task Force is definitely a great step in the right direction. I may be a little biased because the fire department that I work for has a functioning Rescue Task Force in place. I think where it becomes problematic is these high threat incidents really don't fit in a nice, neat box. There's not, we can't design an algorithm that's gonna allow us to effectively conquer any type of high threat incident because they are ubiquitous. They're constantly changing and they're all different. There are some similarities that will kind of come across all of them, but there's some stark differences between them. I think the folks that did the work on NFPA 3000 have set us in a good direction, and I think that the momentum is strong, and definitely from talking with Dr. Eastman and the work that he's done, I think that the group is heading in a good direction. And I think one of the things that definitely has to be talked about within NFPA 3000 is the education of the layperson or the general public, and getting them trained and potentially equipped to be able to control bleeding. Because somebody's going to potentially bleed out in those first few minutes, and it takes time for that Rescue Task Force to get put into effect to be able to get in there and treat or evacuate those victims. So it's those lives that can be saved by the teacher or the lay person that is with that injured party, that can help essentially extend their life clock until the professional rescuers can get there and ultimately get them off to the hospital. But it was a great debate. It was really it was well formed, and I think there were good points on either side.
Something people fail to realize about penetrating trauma is the time factor. And I say that as a European because in Europe, and we're, in my opinion, terrible at treating shooting injuries because we don't see so many of them. And it's really difficult to get people understand that time is a factor. Again, a rescue task force, it's quite an interesting concept, because it means, okay, you need as many guns as you can to shoot to neutralize the bad guy, but at the same time you have patient bleeding, and you have to do something as soon as possible. One of the interesting possibility for the rescue task force is to have educated providers, but around the country. I mean, the street level police officer, the street level EMT, to know the concept and to be able to assemble, to get together, to do a rescue task force in a span of 30 seconds. And that's possible. That, again, as you said, that's a matter of education.
Yeah, I think what people just have to be mindful of is the rescue task force is not the end all be all fix to the situation. It's, those people that have maybe self extricated or self treated, they're going to be able to get out of the scene quicker, maybe by having laypersons take them out or other bystanders. It's the people that are still behind, that still need treated and evacuated. That's where that rescue task force, I think, can come into play.
And just like, once you know one EMS system, one EMS system, the rescue task force can vary and flex and have a very different mission depending on your local municipality. Some of the statistics that Mike was sharing for us is, 75 to 80% of law enforcement departments have a very limited number of officers. So, just assuming that the cavalry is on their way may not be fair, especially considering that, if you're in rural America or a suburban area, you may not have that response. Some beautiful points, and I think rescue task force will remain to be controversial. I think one thing we did agree upon was that just like stopping the bleed, is there an opportunity to use bystanders, to train them, to, give them the skills that they need to maintain composure and calm during these critical events and incidents, so that they might be able to help, and so we know that we advocate for the run, hide, fight for civilians, but what if it was run, hide, help, fight? Deploying a basic tourniquet, etc. I like the idea of making, or getting the basic stop the bleed skills in order to graduate high school. I think is incredibly important in teaching folks, can you apply an AED? Can you apply a basic tourniquet? These are important life skills that perhaps all of our citizenry should be well equipped with.
I found that one of the slides that he put up was the actual municipal training of employees from the municipality being trained in Stop the Bleed, so that every employee of a municipality has a tourniquet, has the ability to apply one. The other thing is the urban versus rural response, and that training the individuals that are in the incident to self-rescue is imperative to the rural environment, because it can take a half an hour for that rescue task force. Even in the urban environment, under a high type incident, 1 October, the rescue task force, all they did was see dead bodies, to quote Mike.
On that very, very bright note, Dave, we definitely wanted to take an opportunity to thank NAEMT. This is an incredible pre-conference for EMS World Expo. We want to thank Dr. Alex Eastman for his leadership in assembling such an all-star panel and roster. It was an incredible time. There were so many take-home messages that we would, of course, never be able to cover in a single podcast. But nevertheless, thanks for joining us. This is Mike Brown, Dave Jensen, JC Pitalud, and Faizan Arshad wishing everyone a safe tour.